Hello, today with this Fern presentation we will be discussing the care of emergency department patients with dizziness and vertigo in an attempt to appropriately diagnose and treat patients with a potential serious central etiology. My name is Edward Sloan. I'm an emergency physician in Chicago. I work with Fern, the Foundation for Education and Research in Neurological Emergencies, fern.org. I have no financial conflicts. I'm the Fern president and board chair. I wanted to go to just a few articles from our Fern National Journal Club that address some of these questions related to dizziness and vertigo, the HINTS testing, and the medical literature. In one paper, the HINTS exam was compared to the ABCD squared test in order to determine stroke and TIA. And what we know is, if you do the HINTS exam plus an assessment for no new hearing loss, this gives us the highest area under the curve for diagnostic accuracy. In other words, if you see here in red the area under the curve, the yellow highlighted portion suggests that the area under the curve is almost 100%, meaning if you do the HINTS exam and check for unilateral hearing loss, you are going to have the best ability to detect and exclude stroke and TIA. From this paper also comes the Send Him On Home Safe mnemonic. What does this mean? Straight eyes, no deafness, head impulse misses, meaning one side has a unilateral saccade. One-way nystagmus, horizontal, not bilateral fast component. Healthy otic and mastoid exam, stands alone, no ataxic gait. And face even, no paralysis unilateral on one side or the other. Another paper addresses the issue of nystagmus and posterior stroke. And the point of this paper is to say that nystagmus can't be used alone for the diagnosis of stroke. What do I mean by that? Nystagmus is often absent in central etiology vertigo. And we know that peripheral appearing nystagmus can be seen in central etiology vertigo. That's why you do the head impulse test and the test of skew. So knowing now that we need to do more than just the nystagmus exam, why is there so much emphasis on truncal ataxia and ataxic gait? Another study suggests that the HINTS Plus exam that includes a truncal ataxia exam is key. In other words, this study demonstrated that 15% of patients had no nystagmus but did have ataxia. In other words, you need to check for ataxia beyond the HINTS exam. So the HINTS exam must be supplemented by a neuro exam to search for truncal ataxia or ataxic gait. Now you might say, listen, the MRI is far more sensitive than any exam that I could do. If I think there's a central etiology, I'm just going to do an MRI. Now what's interesting is the HINTS exam, the physical exam that we've discussed extensively, may detect early stroke even before MRI DWI suggests any changes. In other words, HINTS is more sensitive than MRI DWI early after posterior stroke. Why is that? Because MR at less than 48 hours in a patient with acute vestibular syndrome could be falsely negative in up to 12% of patients. So, if the HINTS testing is 100% sensitive and the MRI is 88% sensitive, that means 12 out of every 100 patients will be missed on MRI that could be detected with your HINTS exam. In other words, about 1 out of 10 or 1 out of 8 patients you will detect on a HINTS exam even when the MRI is negative. Now, what about machine learning? Can machine learning improve upon the HINTS test, looking at the components to determine whether it's central versus peripheral? Well, they actually do have machines that will detect changes on HINTS exam, and we can look and see whether the machine learning provides us any benefit. If you look at this graphical representation of the ability of different tests to detect a central etiology, the yellow line is the HINTS test. And the machine learning is in the purple box plot. And what you see from this is machine learning related to detection of HINTS findings using a machine that will video record the pupil findings. The machine had greater accuracy and area under the curve than the HINTS test alone. What about the patient outcome in our third patient who presented with dizziness and vertigo? Remember, it's a 44-year-old male, hypertension, diabetes, 6 hours of continuous dizziness. He felt like he was drunk, normal vitals. He had left beating rapid nystagmus, and his symptoms were improved with emergency department treatment, and the suggestion was if the CT is okay, he can go home with meclizine. Well, the CT was negative, but is the patient really clear to go? The patient had some decreased auditory acuity on the left, and when noted to be walking and standing, had some mild wide-based gait consistent with ataxia. The patient indeed was admitted. The initial MR-DWI was negative. The subsequent MR at 72 hours was posterior for posterior stroke. And in fact, the patient in this example has right basilar occlusion and posterior stroke findings that are seen here on MRI related to this basilar thrombus. Here is a graphical or pictorial representation of places where you can have disruption in the vertebral basilar system leading into the circle of Willis. And I wanted to reiterate those areas that can be involved in vertebral basilar insufficiency or stroke, including portions of the temporal parietal lobe, the thalamus, the occipital lobes, the brainstem, and the cerebellum. No discussion of dizziness and/or vertigo is complete without discussing EMR documentation. So let's take a look at 3 different dot phrases that can be developed for use in any of the electronic medical records. The first would be a diagnosis of nonspecific dizziness. You would document no evidence of syncope or near syncope, no findings consistent with vertigo, no motion component, no physical exam or test findings detecting or demonstrating a systemic cause, normal cardiovascular exam, normal neurological exam including HINTS testing, patient not orthostatic, normal vitals, EKG, lab testing normal, able to be discharged safely, patient aware and agrees with plan for outpatient follow-up, return as needed. The second dot phrase would be a dot phrase that is related to acute vestibular syndrome. This is a specific diagnosis, continuous dizziness present at the time of ED evaluation. You would say then patient has motion symptoms consistent with vertigo. They have a nonspecific neurological exam. Now, if they don't have a specific finding that would suggest a peripheral etiology, and what are those two? Those two would be either a unilateral horizontal nystagmus and a correcting saccade on head impulse tests suggesting one or the other vestibular systems is ill and malfunctioning. If those are not found and you have acute vestibular syndrome, you then need to admit the patient for further diagnostic testing. because there remains diagnostic uncertainty. Our final dot phrase is related to patients in whom our HINTS++ exam actually demonstrates a peripheral etiology. In this case, your diagnosis is acute vestibular syndrome and likely acute vestibular neuritis. What do we document? From HINTS, we would say there's only horizontal nystagmus, there's no vertical, torsional, or bilateral or bidirectional fast horizontal nystagmus. The HINT test demonstrates a correcting saccade on the left, for example, consistent with left vestibular system dysfunction. There's no vertical skew correction, no facial or extremity weakness, no limb ataxia, dysarthria, speech abnormality or hearing loss, no pain or temperature sensory loss, no diplopia, ptosis, anisocoria, or dim vision, no truncal ataxia in the cart, no ataxic gait, and the patient's able to stand or walk without assistance. This dot phrase supports the diagnosis of a peripheral etiology such as acute vestibular neuritis. In this patient, you would say the patient is well, observed to leave the emergency department without assistance, able to be discharged safely, patient aware and agrees with plan for outpatient follow-up, return is needed, dizziness, vertigo medications provided as indicated. So, is the vertical central? What is our general EMR documentation plan? Have a neurological exam template. Have a specific neurological exam for vertigo patients. Include a template that has HINTS++, HINTS plus hearing loss, plus ataxic gait or truncal ataxia. Have dot phrases for decision making. Be able to document that the patient is functioning adequately, can walk out of the emergency department, and is able to walk, talk, see, stand. Have discharge instructions templated that would suggest what the patient needs to know in order to return to the emergency department, and know that your documentation will enhance patient outcomes because it allows you to know what you must document on history and physical in order to discharge the patient home safely. So let's summarize what we've learned from our dizziness and vertigo discussion today. What are our conclusions? We know that there are clear definitions that allow us to correctly diagnose vertigo and dizziness. We know that if you do the history backwards, that leaves dizziness as a diagnosis of exclusion. We know that syncope and systemic causes can be found for dizziness. We've learned that there are 3 vertigo types: acute vestibular syndrome and spontaneous EVS or triggered EVS. We know that with acute vestibular syndrome, we need to consider posterior stroke, and with spontaneous episodic or EVS, we know a TIA is to be considered. We know that triggered EVS, although often is related to BPPV, can be possible posterior lesion, suggesting possibly the need for CT. And we know we need to do a neuro exam plus the HINTS+ exams in all vertigo patients. We've learned that central signs on HINTS+ are easy to find and document. And we've learned that the HINTS+ is more sensitive than CT and MRI in patients with vertigo and acute vestibular syndrome. So our recommendations as a result of our discussion today: use a reverse history with dizziness, knowing that dizziness is a diagnosis of exclusion. Use your history, physical, vitals, labs, EKG, O2 sat to exclude systemic causes. Consider 3 vertigo types: AVS and then spontaneous or triggered EVS. With AVS, consider posterior stroke. With spontaneous EVS, consider TIA. With triggered EVS, think possible posterior lesion. If a patient has vertigo, Do both a neuro exam and a HINTS Plus exam. Template your central signs from your neuro HINTS Plus exam. And given that the CT and MRI are less useful acutely, in any patient with vertigo and acute vestibular syndrome, use the HINTS Plus exam to guide whether or not you believe it's a central etiology. And then be ready for new technology that will assist in central versus peripheral etiology assessments for our ED patients with AVS and vertigo. So, what are the red light findings in summary? On head impulse, no unilateral saccade observed on either side is bad. Nystagmus, bilateral fast component, is bad, as are vertical and rotational nystagmus. Any correction vertically on tests of skew is bad. Any hearing loss is bad. Truncal ataxia or ataxic gait are bad. And lastly, we know that anterior stroke signs are bad. If any of these are found, red light the patient and admit them for further diagnostic testing. So our final note on peripheral etiology must-haves in a patient with constant dizziness, present at the time of evaluation, diagnosed with acute vestibular syndrome. In order to diagnose vestibular neuritis or labyrinthitis, saying that there's a peripheral etiology, saying that the patient is cleared, they're green lighted to go home with meds, you must have unilateral rapid component nystagmus horizontally only, and you must have one side that has a corrective saccade on head impulse, suggesting that one of the two vestibular sides is ill. The pupils need to be aligned vertically on skew. There need to be no posterior neuro signs or symptoms. The patient needs to be able to sit, stand up, and walk. You need to check for sensory pain and temperature, not just light touch. And there need to be no anterior stroke signs or symptoms, no unilateral facial weakness or extremity weakness, no speech abnormalities, no altered mental status. So some final take-home ideas related to the question, is the vertigo that a patient experiences with acute vestibular syndrome in the emergency department central in etiology? A few take-home ideas. Know the attest system and the three types of vertigo we discussed. AVS or spontaneous and triggered EVS. Know the HINTS Plus exam. HINTS plus checking for hearing loss plus checking for ataxia. Exclude anterior stroke signs and symptoms. Make sure the patient can walk, talk, see, hear, feel, swallow. Observe the patient walking out of the emergency department. Document using templates and give specific return symptoms in your discharge instructions so that if there is any worsening of the symptoms that would suggest an ongoing posterior circulation TIA or stroke, that the patient will return for further evaluation. So let's go back to our educational objectives. What do we know? We did go through our definitions, both from the dictionary and from our consensus group. We know what diagnoses are related to the three types of vertigo. We know how to diagnose central causes. We know how to conduct our history and physical. We know about the attest system and the HINTS Plus exam. We've reviewed a few relevant publications, and we're aware of new technologies that may assist us in detecting central etiologies for dizziness and vertigo in the future. And with that, I say thank you. For any further information, I encourage you to go to fern.org, or we can go to the Fern.org channel and subscribe on YouTube, or you can send us an email at fern.org@gmail.com. Thank you for your time and attention to this important clinical information related to the neurological emergency of acute vestibular syndrome in emergency department patients. I'm Edward Sloan. Again, thank you and have a good day.